Hello everyone. So in this video we are going to take a look at IUD, intrauterine fetal death, causes, diagnosis, ultrasonographic findings and management. So let's begin. Definition: it refers to the fetal demise occurring beyond the period of viability, typically after 20 to 28 weeks of gestation, with a birth weight of 500 grams or more. This results in delivery of a macerated fetus, and IUCD is a distinct form of abortion which refers to the fetal death before viability. So this is something new compared to the abortion. So let's look at, because this is occurring before the period of viability. So let's take a look at, I think we have already seen a macerated fetus. So this is how it looks like. Intrauterine fetal death. So it can't live on its own, that's the thing. Yeah, causes of IUFD, intrauterine fetal death. Let's it isn't much clear to me, so let's take a look at IUFD versus abortion. What's the difference? But the different timings. So this one is after 20 weeks IUFD, placental insufficiency, chromosomal anomalies and a lot of other things, induction of labor, D&D are the management steps. Abortion is the loss of pregnancy before 20 weeks, spontaneous, induced. Yeah, so mainly criteria is the 20 weeks mark where it becomes. So yeah, so it is terminology is stillbirth in this particular case greater than 28 weeks and miscarriage if it is spontaneous. Coming to the causes. So IUFD is a multifactorial and may be related to maternal, fetal, placental, iatrogenic or idiopathic. So first one, maternal. Hypertensive disorders. So preeclampsia. So maybe you can list out almost everything to get the causes of IUFD. Yeah, coming back. So we have hypertensive disorders. We have mentioned all of them. Diabetes mellitus, maternal infections like malaria, syphilis, hepatitis, toxoplasmosis, influenza, hyperpyrexia. This is the first time we are seeing hyperpyrexia in obstetrics. Maternal causes of IUFD, thrombophilias, factor V laden, protein CS, lupus anticoagulant, antiphospholipid antibody syndrome, abnormal labor, prolonged labor, obstructed labor, uterine rupture, and SLE2. So these are the maternal causes. So all of the major diseases that you can think of. That is what it is. Fetal causes: chromosomal anomalies, abnormalities, major structural anomalies, infections, viral bacterial chorioamnitis, RH incompatibility leading to hemolytic disease, non-immune hydrops, intrauterine growth restriction. So these are the fetal causes: chromosomal abnormalities, major structural anomalies, infections, RH incompatibility, non-immune hydrops. Let's take a look at this. IUGR, growth restriction, retardation, restriction. Yeah, restriction. Always it is little bit different. Yeah, confusing. Non-immune hydrops. What is it? Hydrops fetalis is abnormal fluid collection of at least 2 fetal compartments without evidence of maternal fetal blood group incompatibility. So this is the only thing, this is the thing that's missing. So we have different compartments here and causes. Okay, heart related causes, TTTS, chromosomal causes, anomalies, thoracic causes, infections, hematological. Yeah, so yeah, maybe so some diseases cause immune hydrops fetalis except the mismatch. IUGR we already know, and we are going to learn it in the later sections too. Placental causes: antepartum hemorrhage, cord accidents, twin to twin transfusion, and placental insufficiency. These are the placental causes. Iatrogenic causes: external cephalic version, drug related causes. So these are related to iatrogenic. Finally, idiopathic, what we do in the hospitals. Yeah, that has caused this. Idiopathic causes: no identifiable cause despite thorough examination. Coming to the diagnosis. Diagnosis of intrauterine fetal death, demise. So what do we do? There are signs and symptoms, and then there are investigations. We used to confirm the diagnosis. So signs, symptoms: absence of fetal movement noted by the mother. So self-explanatory. It is dead, so it can't move. Signs: gradual regression of fundal height. It is getting macerated. Uterine tone diminished. Uterus feels flaccid. Absent fetal heart sounds on auscultation. Fetal movements absent of palpation. CTG flat trans and eggshell cracking of fetal head, which is the lead sign. So again, gradual regression of fundal height, uterine tone diminished, uterus feels flaccid, absence of fetal heart sounds on auscultation, fetal movements absent of palpation, CTG flat trans and eggshell cracking of fetal head. Coming to the investigations, specifically we are going to look at the ultrasonographic findings. So USG. So sonography, lack of fetal cardiac activity. Yeah. Real-time sonography observation for 10 minutes. We need to do this to confirm it. Next, coming to Doppler ultrasound, absence of umbilical artery flow, and X-ray abdomen, there is Spalding sign, hyperflexion of the neck of the spine, and gas shadowing in heart and vessels. So these are the things: Spalding sign, overlapping cranial bones due to brain liquefaction, hyperflexion of the spine, gas shadowing in heart and vessels. So that is X-ray abdomen. Let's take a look. So I am feeling a little bit sleepy today due to some reason, and that's why I can't think clearly. Yeah, but we will try our best to understand some topics. Spalding sign refers to overlapping of fetal skull. We have seen this by the collapse of fetal brain. Where have we seen this? Is it? Yeah, it is in this one, forensic mostly. Yeah, it's in forensic. It is Spalding sign, forensic medicine. Is it there somewhere? I can't find. Infanticide may be somewhere there. Yeah, coming back. Yeah, I think it was forensic. Yeah, hyperflexion of spine, gas shadowing of heart and vessels. So this is gas shadowing of heart and vessels. We didn't even look at the image. Should we look? Yeah, overlapping of fetal skull bones, that is Spalding. Next, coming to Roberts sign. Roberts sign, what is it? Presence of gas shadow in the great vessels. Gas shadow in the great vessels. Where is it? So maybe there are. I can't understand it. That's the problem. Maybe because I'm not a radiologist. I have not received enough of training there. Coming to blood tests. So coagulation profile, and what is this? Klehover-Bethke test. Let's understand what this is. So it's a laboratory test to detect and quantify presence of fetal red blood cells in maternal circulation, helping to estimate the volume of feto-maternal hemorrhage. So this test, presence of fetal red blood cells in maternal circulation, helping to estimate the volume of feto-maternal hemorrhage. So coming to the principle, should we go through it? Fetal RBCs contain HbF, which is resistant to acid elution. Maternal RBCs contain this one, and yeah, something related to the antigen antibody. No, not antigen antibody, it is treated with acid, and fetal RBCs remain intact and appear bright red stained with eosin. The proportion of fetal cells in the maternal sample is then calculated. Yeah, something related to the hemorrhage. Not going in detail. It can come in Viva though. They'll ask. What will I tell them? So I can't speak about some random thing. So let's just know this. It's a test used to detect and quantify presence of fetal red blood cells in maternal circulation, helping to estimate the volume of feto-maternal hemorrhage. And torch screening for infections. So again looking at it is the diagnosis IUFD, intrauterine fetal demise we are looking at, and specifically there are some signs in the investigations part. So we have looked at fetal heart activity and absence of umbilical artery flow. Then there is Spalding sign, hyperflexion of neck, and Roberts sign, looking at heart and the vessels. And there is also this one specific that we looked at, Klehover Beatke. Is that the right pronunciation? I doubt that is the case. Torch screening. Yeah, so those were the things. Coming to ultrasonographic findings. So Spalding, we have already seen this. Collapsed fetal skull, oligohydramnios, echogenic amniotic fluid due to maceration and sloughing, and gas shadow in fetal heart and great vessels. So let's take a look. No, not here. Here. No, here itself. Sorry about it. Little bit. Very echogenic amniotic fluid has been variably attributed to meconium blood or Vernix caseosa. However, the most previous reports. Amniotic fluid, fetus, umbilical artery. So echogenic amniotic fluid. Yeah, so this is the color. So it is colorful. It shouldn't be colorful. That's what they are talking about. It should be black. But here it is. Here it is colorful, echogenic. Yeah, that's it. Gas shadow in fetal heart and great vessels. We'll try this again because don't give up. Gas shadow in. So there is left lung, heart. Here is the gas shadow. So this is the right ventricle, right atria. So where is the gas shadow here? This one. This is the only thing that I can't understand properly. Roberts sign. Anyways, we'll go to the next one. Management of IUFD. Management aims to prevent maternal complications such as DIC infection while ensuring psychological support for mother. So expectant management, indication of early delivery, methods of early delivery, and postpartum care. So first one, expectant management. 80% of the cases, spontaneous expulsion occurs within 2 weeks of the IUFD child, a fetus. Regular fibrinogen estimation every 2 weeks to assess risk of DIC, and psychological support for mother and family. So we want to know why DIC occurs, why DIC in, maybe some leaks or something, why DIC in IUFD. We need to know. I'm not clear with the mechanism. Due to prolonged retection of dead fetus leading to hypercoagulable state. Release of thromboplastin. Yeah, that's the main one. Thromboplastin is released. Psychological support for mother and family. Indications of early delivery: psychological distress, signs of intrauterine infection, prolonged retention of pregnancy, decreasing fibrinogen levels. So these are the things. Indications for early delivery: psychological distress, signs of intrauterine infection, prolonged retention of pregnancy, and decreasing fibrinogen levels. Coming to methods of delivery. So methods of delivery dependent on various things. If there is favorable cervix, induction using oxytocin infusion. If unfavorable, a combination of mifepristone and misoprostol for cervical ripening followed by oxytocin infusion. Mifepristone and misoprostol. Misoprostol 25 to 50 microgram vaginally every 4 hours is an alternative, and caesarean section is rarely indicated except in cases of multiple prior LSCS. So again, if cervix is favorable, oxytocin infusion, so that it is like a normal labor. If unfavorable cervix, mifepristone and misoprostol for cervical ripening followed by so cervical ripening is what we want. Misoprostol 25 to 50 microgram vaginally every 4 hours is an alternative, and caesarean section is rarely indicated except in cases of multiple prior LSCS or major placenta previa. So that comes with that, we come to the end of this methods of delivery. Postpartum care. cabergoline to suppress lactation. We don't want lactation because baby is no more. Bereavement counseling for psychological support, management of underlying maternal conditions which have caused this in the first place. Yeah, so what did we look at in management? Expectant management. For the regular one, we look out for DIC and psychological support. Indication for early delivery, that is psychological distress, intrauterine infections, signs for that, and retention of pregnancy, prolonged retention and decreasing fibrinogen levels, again for DIC. And methods of delivery we have seen. For favorable cervix, we do oxytocin. Unfavorable, we do mifepristone misoprostol followed by infusion, and misoprostol 25 to 50 microgram every 4 hours. And cesarean section rarely indicated. Postpartum care, cabergoline to suppress lactation, bereavement counseling for psychological support and management of underlying maternal conditions. So with this we come to the end of the discussion on intrauterine fetal death, which was a good one. Yeah, anyways, in case you like this particular video, you can like it. In case you would like to watch more, you can subscribe. Bye.